Hello, everyone. Welcome to this Medscape educational streaming program entitled Under the Hereditary Angioedema Microscope, Navigating the Latest Advances in HAE at the 2024 American Academy of Asthma, Allergy, and Immunology meeting. I'm Dr. Marc Riedl. I'm a allergist immunologist and a professor of medicine at the University of California in San Diego. And I'm joined this evening by my friend and colleague, Dr. Bill Lumry. Dr. Lumry, you want to introduce yourself quickly?
Sure, Mark. Pleasure to be here. Thank you. My name is Bill Lumry. I'm a practicing allergist immunologist in Dallas, Texas, and a clinical professor at the University of Texas Southwestern Medical School and medical director of the AAAAI Research Center.
Excellent. Thanks, Bill. And you see here on the slide, Dr. Jonathan Bernstein, a fellow colleague of ours, was also supposed to join us. Unfortunately, his travel plans interfered with his ability to make the live event. So we'll miss Dr. Bernstein, but we'll try to fill in for him the best we can. And just a quick reminder, since this is streaming live on various social media platforms, you do have the opportunity to comment, to send questions through those platforms. We will do our best to save a little bit of time at the end to look at those comments and perhaps answer a few questions, time permitting. So please feel free to participate in that fashion if you'd like. But our main goal for the next few minutes is a couple of things. Number one, as the title suggests, we're going to talk about hereditary angioedema a bit, but we're going to fairly quickly move into what's new, what's coming out as far as studies, as far as data, as far as new information at the AAAAI meeting, which will be held in Washington, D.C. In a few days. And so we're going to kind of go rapid fire and give you a preview of some of the HAE abstracts that we felt might be of considerable interest. Of course, we only have the abstracts, so stay tuned during the meeting to hear more details about these topics. But if we go to the next slide and one more, I'll just provide a very brief introduction or a review, if you will, on hereditary angioedema and specifically the pathophysiology. This is a busy slide, but if you concentrate on the middle of this slide, much of what we understand about hereditary angioedema is that it is a genetic disorder that causes unpredictable swelling events because there's dysregulation of the contact system or the so-called kallikrein bradykinin system. And so again, focusing just on the middle here, in the red outlined text, there is a C1 inhibitor protein. Most cases of HAE are caused by a deficiency, a genetic deficiency of that protein, and that leads to unimpeded activation of both factor 12 and kallikrein, which ultimately leads to excessive bradykinin production. And that's there at the very bottom center of the slide, where bradykinin hits that B2 receptor and causes the vascular leak that we recognize as angioedema symptoms of the skin, of the GI tract, of the airway. And so just to take away from this before we move on, a couple of things. Number one is that this understanding, this mechanism has led to really a lot of developments in terms of managing HAE. We're going to talk about some of those treatments, both existing and also investigational treatments that are being developed, because there's a lot of data coming up at AAAAI talking about how we're managing HAE. And the other thing that I would point out here is that we still have a long ways to go in terms of diagnostics for angioedema. We can measure C1 inhibitor levels and function, and that's very effective for identifying C1 inhibitor deficiency, so-called type 1 or type 2 HAE. But those of us in practice would all recognize there are lots of angioedema patients that that testing is normal. And so we're still left unable to really identify this specific mechanism that causes some types of angioedema. So, Bill, anything you want to add to that before we jump into some of the abstracts?
Well, I think just an understanding of the contact activation system and where we can intervene, either by replacing C1 inhibitor, interfering with plasma kallikrein activity, or blocking the effects of bradykinin, helps understand the medications that we're using now, as well as the medications that are in the pipeline.
Yeah, excellent. All right. So if we go to the next slide, we'll start with some abstracts here. And The first abstract I'd like to show you on the next slide is is an abstract on diagnosis. Here we go. I mentioned that we have somewhat limited biomarkers or diagnostic tests, and this is an interesting abstract that will be presented on trying to measure bradykinin levels. So as people may know, that's been a difficult task, meaning that it's been very challenging technically to accurately measure bradykinin in human beings in vivo. And this is a group that's working on this issue. Just to briefly mention what they're going to report, they have basically taken samples from different types of angioedema patients, including HAE due to C1 inhibitor deficiency, idiopathic angioedema patients, HAE with normal C1 inhibitor, which is a very rare condition, but one that's we really lack good testing to confirm the diagnosis. And they've measured and compared these bradykinin levels in these patient groups compared to normal healthy controls. And they're using liquid chromatography, tandem mass spec, which is a technology that allows you to detect bradykinin. And interestingly, their abstract reports that they are able to detect differences, much higher levels in those patients that have been diagnosed with a bradykinin-mediated angioedema compared to those to normal controls, and also are able to sort of detect differences between type 1 and type 2 HAE versus HAE with normal C1 inhibitor. So I'm looking forward to seeing this, because if this can be validated and we understand the sensitivity and the specificity of these measurements, this would be really helpful in the clinical setting when we need to try to determine what's the underlying mechanism of a patient that has recurrent angioedema. So with that, Bill, I'll turn it over to you, and I think we're going to move along to a different topic.
One of the issues in treating patients with hereditary angioedema, or for that matter, any disease, is to understand what burden that disease places on them. In hereditary angioedema, it's more than just I have swelling attacks that interfere with my life. There's a whole process of things as shown on this slide that we took from an excellent work by Alina Banerjee from several years ago, looking at really how HAE can affect patients and where it affects them. One, what about the disease course? There's often delayed diagnosis. The onset is typically in childhood, but in the past, before we had really recognition of this disease, it would take 10 or more years before an accurate diagnosis would be made. Improper treatments and surgeries would often be applied to try to treat these individuals, and that's still going on to some degree, more outside of the United States than in the United States itself. Then there are the attacks, which is the manifestation of the disease. These localized swelling that can affect the periphery, the hands, feet, face, can affect the gut, can affect the airway. And these attacks are at least debilitating and disfiguring, but they can be life-threatening. They're painful, they're prolonged, and probably the most worrisome is that they're unpredictable. Patients don't know what the next attack will bring. Then there's the treatment. Fortunately, over the last 10 years, we've developed now 7 very effective HAE-specific treatments, both for stopping attacks as well as preventing attacks. But these aren't accessible to everybody, certainly not patients outside of the United States, where HAE-specific medications are not readily available. And then there's the cost, both the direct cost of medical care and medications, hospitalizations, but also the indirect costs of loss of work and school productivity, loss of time with family and friends, which obviously adds to the significant burden of disease. On top of that, individuals that are plagued with a hereditary angioedema are often anxious, they're often depressed, and their quality of life is significantly diminished, leading them not to participate in social activities, leading them not to want to travel, leading them to pick jobs or certain school activities that won't trigger attacks. So there's a lot going on here. And the good news is, with both the abstracts at this meeting, we've delved quite deeply into this burden and look at how different populations are affected by the disease. So if we'll go to the next slide, we can look at one of the abstracts. And this first one, in clinical research, we often don't have an opportunity to look at unrepresented racial or ethnic groups. And Dr. Timothy Craig and his group from Hershey, Pennsylvania, have done a very nice job of surveying 139 patients with HAE from either unrepresented ethnic or racial groups. He looked at adults, individuals over the age of 18 that had either a type 1 or type 2 diagnosis. They were residents either of the United States or Puerto Rico. 33% were African American and 30% were of Hispanic or Latin origin. 82% were female, 46% had an annual household income of less than $50,000. So before they were diagnosed, their healthcare providers were seeing in the diagnostic journey, often not turning up the correct diagnosis and requiring them to go to the emergency room sometimes 5 or more times a year. Hospitalizations were 3 times a year. But after diagnosis, this population who had received appropriate treatment, including prophylactic therapies, 80% of them said they took their medication, and since they were diagnosed, they not only reported excellent symptom control, but a significant decrease in healthcare utilization in the hospital and other urgent care and emergency room visits. So able to show that in these populations that have historically been unrepresented or not able to access excellent healthcare like the rest of us are, that we are making a significant difference. Now, there are several other national abstracts, primarily from Colombia and from Brazil. Annette Grumack in extract 280 looks at how HAE, when it's poorly controlled, affects adult patients. And it shows very clearly that individuals that don't get an early diagnosis, that have delayed treatment, who don't have access to good medication, suffer greatly, women more so than men. Dr. Zwiener, in another survey, also in the Colombian population, looked specifically at both adult and male and female patients and showed that again, these individuals, if they weren't recognized and treated appropriately, that they had a significant impact on their quality of life. There are actually several other abstracts from the international community: Oscar Correa Jimenez, number 238, and Jose Lemos, number 248, looking at the Brazilian registry, and another Colombian extract. Look at what's causing the burden in this population. And again, the theme is they don't have access to modern medications. They don't have access to healthcare. Their disease isn't recognized and they're not properly treated. So with these registries being formed, with this knowledge coming out about what's going on in these countries, hopefully it will improve the care for these individuals and decrease the burden that they are experiencing. Next slide. We could have the next slide. So Mark, do you want to talk a little bit about our goals of therapy and how we're addressing this disease at this point in time?
Yeah, thanks, Bill. I'll say a few words here about the treatment strategies and the goals of therapy. And this is just a reminder that we have these ways to treat HAE. These are all outlined in the evidence-based guidelines that have been published, whether you look at the US or international guidelines. And importantly, on-demand therapy is treatment that's designed to stop an attack when it occurs, to rapidly relieve or stop progression of that attack, minimize the severity, minimize the duration of that event. And that should be available and used by any and all patients that have an HAE diagnosis. On the far right, you have the long-term prophylactic approach. This is medicine given on a regular basis that's designed ideally to prevent attacks, but at the very least substantially decrease the number of attacks and the severity of those angioedema episodes. And long-term prophylactic therapy is increasingly being used in many parts of the world because of the benefits of preventing people from getting ill from angioedema. The guidelines still recommend discussing this with all patients, but recognize that not all patients may elect to go on long-term prophylaxis or may have access to long-term prophylaxis in some parts of the world. And then in the middle, short-term prophylaxis, which is designed to give a medicine just prior to a triggering event, medical procedure, dental work, something that we know has a very high risk of triggering HAE symptoms. So again, the purpose of this is just to sort of outline these approaches, because there's a lot of data now coming up at the Quad AI on these different approaches, both how are we doing now and how might we do in the future with some of the investigational medicines that are in development. Next slide.
So this is an interesting abstract that kind of leads the discussion, particularly as it applies to newer medication that is going to be discussed at this particular meeting. This is a survey that was done by Joan Mandeville, John Anderson, and others that looked at why patients don't treat all their HAE attacks. If you look at the HAE guidelines, both the US guidelines and the WAO guidelines, the recommendation is that every attack is or should be treated, and should be treated early to prevent the morbidity and potential mortality of an uncontrolled attack. It turns out, looking at the data from this particular abstract, that only about 50% of patients will treat their attacks. What they looked at was a physician's medical chart data in the US and asked the question, did patients use or not use their on-demand treatment? So they surveyed charts from 65 physicians, 258 HAE patients, and found that about 80% treated their most recent attack. And the most commonly used on-demand medication was an injectable medication, icatibant. Some used intravenous C1 inhibitor, either plasma-derived or recombinant, and some took additional steroid therapy. But the reasons that patients gave for not treating their attacks were, I think, the most interesting part of that. They either felt that their attacks at the beginning were not really severe enough to treat. 60% of the patients said that, or some said they didn't even have an on-demand treatment to use for an attack. The 28% of the physicians said that they felt that the attacks that weren't treated were just as severe than the ones that the patients actually obviously treated and resolved. So there's a series of other abstracts which we're going to talk about today, but there's about 6 other abstracts that look at why people don't do this. Some of it is because of the anxiety about using the medication. Some of it is not wanting to have it with them or being embarrassed about taking it. And it all leads up to, we need a better on-demand strategy, that we need to have something that's easy to take, that doesn't hurt when you use it, that works effectively and is well tolerated. And hopefully we're moving that direction. But this particular abstract 026 really sets up that whole discussion about, can we do better with our on-demand therapy, which all of these patients need. Next slide. So these are a few of the other abstracts that I mentioned. Connie Catalaris, these all came from surveys that were done by the Hereditary Angioedema Association in the US, asking patients about what they do in certain situations. In Dr. Catalaris's abstract, how many patients are needing to take an extra treatment? And it turns out that about somewhere between 20 and 30% of patients often will have to retreat after retreating the first time. And for the most part, they're using the same medication again. Dr. Wedner's group out of Washington University looked at the same survey results and found that anxiety about on-demand treatment was significant. And because of that, patients delayed their therapy or didn't take their therapy at all because they were anxious about how the actual treatment might make them feel. And then Sandra Christensen and Princess Obugu looked again at other survey results and asked similar questions. Why don't you treat? Why are you waiting an hour or two to treat an attack? Why don't you just jump on it right away? And the results were very similar to the other 2 abstracts, saying that the therapy hurts. I don't want to carry it with me. I'm embarrassed. I leave it at home. I just don't want to take care of it. So again, pointing out very clearly that we need an effective, easy to take, well-tolerated medication that can help our patients abort these attacks once they start. Next slide. So Paula Bussey in abstract 265 looked at how on-demand treatment affected quality of life in patients. And this again came out of an HAEA survey that she conducted with others between September 6th and October 19th, 2022. There were, out of the 107 patients that were treated, and these were all type 1, type 2, 44% of the patients said that they actually adjusted their daily lives to avoid triggers rather than carrying an on-demand treatment with them away from home. And they gave reasons for not taking on-demand treatment, and they were to avoid having to check a bag at security at the airport. The first world problem there. I don't want to check a bag at the door. People feeling that more anxious about on-demand treatment because it hurts, or those under the age of 40, interestingly, said that they were embarrassed about having to treat something, and therefore they were avoiding triggers and situations where their treatment might be discovered by others. Embarrassment, interesting, was one of the major reasons in adolescents in delaying their treatment for more than an hour because they didn't want to take their treatment with them. So it's again, all pointing towards we need something better for these patients that may be easier to take and effective. Next slide. So Mark, do you want to talk a little bit about a couple of the newer medications in the prophylactic realm?
Yeah, so let's talk about treatment a little bit more now. You highlighted some of the important abstracts about on-demand or acute treatment, and to your point, Bill, we haven't had a real advance in HAE for on-demand treatment in about a decade, give or take. So it is ripe for improvement, I think. But before we turn to investigational drugs, there's a couple of important data sets here on currently available treatments, and most of the emerging data right now, other than what you just showed, Bill, is on the long-term prophylactic medicines. We have seen considerable advances in recent years. And so here's a couple abstracts. The first one here is on berotralstat. This comes from Laurent Bouillet and her group in France, where they have a registry that's following patients on this oral daily kallikrein inhibitor berotralstat. And they basically report in these 64 patients that they've been following as part of this program that generally the drug has been well tolerated. They do report some GI symptoms, which we know about 15% of the patients with abdominal pain, about 10% with some diarrhea, but mostly patients are doing well on the drug, and only about less than 10% actually discontinued due to any side effects. And importantly, they're seeing good efficacy consistent with the clinical trials. So at a year of treatment, at 6 months of treatment, that they're getting over a 50% reduction in mean attack rate per month on berotralstat. So this is sort of reassuring data. It shows that we're seeing the same tolerability, the same safety, the same efficacy that's been seen in other data sets in this nice report. The second abstract here is from Dr. Bernstein and colleagues, and this really looks at lanadelumab. There is a study called the Empower study, and the Empower study is a 24-month interim analysis of this phase 4 observational trial of people on the medicine. And again, similar theme, basically shows that these 102 patients that are on the medication had overall a 79% reduction in their attack rate in this 24-month interim analysis. And in fact, that their quality of life scores improved, their angioedema control test scores improved. So again, documenting in the real world now this really substantial HAE attack reduction, improved quality of life, and control of HAE on lanadelumab as a long-term prophylactic therapy. Next slide. And then if we turn to emerging therapies, so I'll say a couple words about these first two abstracts. The first one is from Dr. Toshjian is the first author. This is some additional data on donidalorsen. And donidalorsen is an RNA-targeted therapy subcutaneously given generally once a month, although we're now seeing some data given every 2 months, but appears in phase 2 studies, which we have available to be an effective prophylactic treatment. You can see this is an open label extension study comparing 1 year of treatment versus 2 years. And again, in this about 14 patients that went out to 2 years, which was 82% of the phase 2 study enrollment, that we're seeing consistent reduction in attack rate. So overall, a 96% reduction in attack rate from the baseline into year 2. And again, improvements in quality of life scores. So appears to be very durable in this longer term data set for donidalorsen. The second abstract is on deucrictibant. This is an oral bradykinin 2 receptor antagonist being studied both for on-demand treatment, but here we have data from the phase 2 preventative trial And so this is sort of right off the presses because they just recently released some data publicly showing that in these 34 participants in the deucrictibant preventative trial, that at the higher dose, 40 milligrams per day of deucrictibant, they saw an 84.5% reduction in angioedema attack rate. So really comparable, not head-to-head, but comparable with what we've seen with the sub-Q treatments that we're using widely now. And importantly, the medicine was well tolerated, no serious adverse events, no adverse events leading to discontinuation. So we look forward to digging into that trial data, but this is important news for oral prophylactic investigational drugs. Bill, I'll let you say a few words about the third abstract there, as you are the lead author.
Thank you, Mark. So as I was talking about when we were going through the ways that this disease may burden individuals, one was frequency of dosing. And although we have drugs now that we can give, as Mark said, maybe out every 8 weeks, the patients still have to treat themselves that frequently. This study was the sort of final results of a healthy patient population that was treated with a plasma kallikrein antibody that had been modified, an FTE modification, which rather than the antibody being destroyed, it's actually recycled. So its half-life is much, much longer than a standard monoclonal antibody. These individuals were treated with 300, 600, or 1,200 milligrams of STAR 0215, this modified antibody, and monitored to see how long their plasma kallikrein activity would be suppressed. And it was very clear that even at the 600 milligram dosage, that these individuals had suppression that was significant enough to block HAE attacks. In obviously, these folks didn't have HAE; they were normal, but they were blocking it at a level that they could be dosed every 3 or even every 6 months and achieve the same results that we're seeing with the every 2-week or every 4-week plasma kallikrein antibody that's currently approved and used. So this is exciting. This obviously was not done in HAE patients. Those studies have begun in phase 2, and studies are ongoing with plans to move into phase 3 sometime later this year. But exciting news that we're now able to potentially treat these individuals once every 6 months and achieve the same kind of results that we do now with what we have, thereby hopefully lowering the significant burden of treatment in these individuals. Next slide.
All right, Bill. So we got 2 minutes and 3 abstracts. So I'm going to speed round. So quickly, this is additional data on garadacimab that'll be presented. This is a integrated safety and efficacy analysis. So across all the development, the phase 2, the phase 3, and the open label. And the upshot here is very encouraging data. 172 patients in this analysis, a median of 1.2 years of treatment and observation. So over a year's worth of treatment on median. And they're seeing a very good safety profile. Most common related side effect is mild to moderate injection site reactions with this monthly sub-Q preventative medicine. And pretty remarkably, the efficacy overall is a 94% reduction in mean attack rate. And 57% of these people were attack-free during the treatment period. So again, we're seeing these remarkable advances in efficacy, appears to be quite safe, and with monthly dosing of this monoclonal antibody. Next slide. I'm going to take a moderator's prerogative and just tell you shared decision-making is good. That's what Dr. Bernstein showed. He did a nice survey between docs and patients, but shared decision-making is a good thing, and it looks like at least most experts in HAE that he surveyed are engaging in this. So hopefully he can add more to that at the meeting. And the next slide, just the last abstract we'll cover. This is the late-breaking session on sebetralstat for on-demand treatment of HAE attacks. So as Bill mentioned, we've really tried to move towards more convenient, effective on-demand treatment. This is an oral kallikrein inhibitor taken at the time of an HAE attack. And just quickly, they have just publicly released some of this data earlier a week ago. And so I'll just tell you the upshot here is that this study met its primary endpoint. In fact, the median time to beginning of symptom relief was significantly shorter for the oral treatment versus placebo. 1.61 hours to the onset of symptom relief for the 300 milligram dose of sebetralstat versus 6.72 hours for placebo, and also showed faster time to reduction in attack severity, faster time to complete symptom relief compared to placebo. Also showed a very good safety profile with really comparable low level of side effects between the drug and the placebo. So much more detail will be given at the Academy meeting, but I think this is an exciting development for HAE therapeutics. So Bill, we made it almost. We got through a lot of information. As we close, any last parting words of wisdom to our audience out there?
No, I think we're continuing to move the ball up the mountain. We're finding better, longer lasting, easier to take, less side effect associated medications in this population that was so underserved for so long. So we just kind of have to keep working at it.
Absolutely. I couldn't agree more. And we want to thank all of you for participating in the activity. Certainly hope to see many of you at the Academy meeting in Washington, D.C. in a few days. Thanks again for joining.
Great. Good night.